I'll start with, this topic is close to my heart for more than one reason. And we know that we're seeing a lot of young deaths now, which are attributable to cardiovascular risk. And most of us think that maybe we are genetically predisposed. Some of us think that, there is probably a post-COVID scenario that we're seeing a lot of young deaths occurring because of sudden cardiac deaths or cardiac diseases. So, as I say, data is God. I'm going to show you some data which is startling, to say the least. We should be aware of that because that's going to set the tone for what I'm going to talk about. Next. Yeah, so when we talk about emerging risks, next please. Now, if you look at the Indian scenario, it's a unique conundrum. We are nearly 1.3 billion people, reaching 1.4 billion. And if you look at the number of people who are actually less than 55 years or 60 years of age, they are 730 million or so, which is 60% of our population is young. Now, Now, isn't that nice? Because we have the demographic dividend, we have a young population, nearly 60% of that population is worker class, and we have the demographic dividend to go forward and do very well in economic and social sense. But it also brings to the fact that, next please, it also brings to the fact that these people, which brings me to the next component, which is that this working class is also prone to, it's the most productive class, it is the elephant in the room as we're talking, it's another elephant in the room, where this working class is most prone to heart diseases. We are a young nation, so you are going to see much more number of patients coming with heart disease who are in young bracket, between 15 to 59 or 15 to 60 years bracket. So numerically, we will have more and more heart diseases in the young. Now, if you look at, let's go back 15 years and look at the data. In 2007, cardiovascular diseases were the highest cause for death across the world. Nearly 50% of deaths occurred because of cardiovascular diseases, 2007. And if you look at very interesting data in 2007 again, the major cause of death at that time was again cardiovascular diseases. And this is in low and middle income countries. And you're look at on the right side of your panel, and the first two causes of DALYs, or disability-adjusted life years, where you're losing productive years of a worker, were number one, occupational injuries, number two was mental health, which Dr. Samir was talking about, and number three is cardiovascular diseases. And this is 15 years back. We should have done something about it, but unfortunately, I don't think enough was done in that regard. And let's fast forward to 2021 data. You look at the number of deaths which has happened, or which is global mortality, the leading causes of death in 2021, or now, today. The first is hypertension. The second is dietary risks. The third is the second is tobacco, the dietary risk, and the fourth one is air pollution. Now, you're sitting in Delhi, which has probably the highest level of air pollution. And these are the new risk factors which have emerged in the last 15, 20 years, which we need to look into. There are other behavioral and environmental factors which are listed there, which are very common sense risk factors, but we know that they are the major causes of death and morbidity in the coming few years. And that is what we need to focus on. Now, you look at hypertension. The orange one is India, the gray one is US, and the blue one is global. The world. Look at India. India has the highest number of hypertensives in comparison to the global numbers, in comparison to US. US is more obese, so they have the BMIs are higher in US. Other than that, high cholesterol, high sugar, and hypertension are more in India as compared to our global disease. If you look at the top 10 countries about diabetes, we are just behind China. But what is more alarming is that from 2020 to 2045, in 25 years' time, we will be having a jump of nearly 100% from 74 to 124, nearly doubling of the diabetics in India. And we know that there is a 2 to 4-fold increase in cardiovascular diseases in them. If you look at the mental health or disorders in the young, on the left side you have females, on the right you have the males. You can see depression, anxiety, self-harm, suicidal tendencies are rising over the last 15 years, and we've already had a talk on that. Women are a special subset. Now, if you look at the problems which are affecting women today, very little is talked about. Men and women aren't the same. They have different needs and medical issues right from the day they're born, infancy to old age, including menopause when they're growing up, which puts them at higher risk of heart disease and many other issues. Now, air pollution, another elephant in the room. Nobody wants to talk about it, but look at the impact air pollution has today. There are multiple pathways, mechanistic pathways, which leads to heart disease. And if you look at the global averages, the PM 2.5 pollution has a direct link with the cardiovascular diseases, and we're seeing that every day. Now, coming to the cardiovascular epidemic. If you look at the world average, so let's fast forward from 2007 to 2018 data, and we still have cardiovascular diseases at the top. They're causing 50% of death world over. And look at India and China. In 10 years' time, we're having an increasingly more and more people going towards cardiovascular disease and death. We are seeing, so basically what I'm trying to say is with that data in the background, we need to change that. And 75% of all these risk factors which lead to heart disease are modifiable. So they're all risk factors which is related to your environment, behavior, metabolic risk factors, and all of them can be changed, like hypertension, diabetes, mental stress, air pollution. All these risk factors, high cholesterol, sedentary habits, diet, and all these need to be looked into for future references. Now, if we go by this is a very interesting study which is about childhood. If you look at the childhood data, the Young Fin study, adult health study, the atherosclerotic cardiovascular disease is actually rooted in children. It starts from childhood. It's not that an adult is going to get it. And that's why by the time they're 25, 30 years of age, we're seeing more and more heart attacks coming in. In fact, Indian scenario is more disturbing because you're seeing more young people getting heart attacks. Nearly 1 in 25 below the age of 40 and 1 in 4 below the age of 55 is getting coronary artery disease today and heart attacks and strokes. So going forward, if you look at the regional tendencies, in India, current tobacco and alcohol is seen more in Northeast. Hypertension is common both in North and South India. Look at the physical activity levels are much lower in North India, and metabolic risk factors are also more common in South India. And that's why there is a higher clustering of risk factors, more than 3 in South India, and higher risk of cardiovascular diseases in South India as compared to the other parts of the country. Now, risk scores is how you catch them young. You need risk scoring. The closest risk scoring that we actually use in Indian or East Asian subset is the Q risk score or the JBS score. Framingham risk scores, etc., are not so much applicable to India because of the age factor. We get age, heart disease at least 10 to 15 years younger in India as compared to our Western counterparts. So with the help of these risk factors, we can intervene with what is known as the best buys. The WHO causes the best buy interventions. So you have the tobacco use, you can have higher taxes, health warnings, you have the unhealthy physical activities, etc., can be curtailed. And by these recommendations, so-called implementation, we are able to control the risk factors much more effectively. The other is immunization, which Dr. Guleria talked about, is again coming into the work area. So workplace interventions are the norm. They are very, very effective. They definitely make a difference. There is a very interesting data which talks about the physical activity paradox. So the leisure time activity versus work physical activity is different. If you are having a higher physical activity at work, it leads to more mortality and death and misery as compared to your leisure time physical activity. Now, this is a 2021 data. That means the physical activity at work, especially when you're in mining industries, physically demanding industries, the mortality is actually going to be higher. That cannot be translated into a leisure time activity, which again puts you at occupational health scenarios where you must promote leisure time activities. So they work, they definitely work, and the workplace interventions are important because they mean money. $1 spent on these welfare schemes will lead to $7 as an ROI for the people who are interested in that aspect. I'm more interested in the social aspect, but I know economy matters. So if you look at the collateral benefits, it benefits both at social and economic level, and the workplace interventions play a big part and have a multitude of impact. Now, future directions, these are my last 2-3 slides, is very important because you have the concepts of polypill, which is coming up with or without aspirin, which has shown that in intermediate risk patients, they may work. You have the concept of mobile health. So you have a lot of gadgets like watches and Fitbits and bands which are coming in, which can capture your physical activity, can pick up atrial fibrillation, etc. You have future digital integration like the eye-track system, which integrates the goal-directed medical therapy, guideline-directed medical therapy into your platforms. And you also have an integrated World Heart Federation model for digital health. Now, what we have proposed is to actually bring in this future of CVD prevention in the form of digital health. So we capture the data with the personal EHR of the patients, the diabetes, the risk factors through the Q-risk scoring. We translate into the risk, mild, moderate, severe risk categories, and then do the appropriate interventions which are on the right. So we do appropriate tests, investigations, and take a leap forward. So AI is the future. Deep learning and machine learning is going to be your future, and that is going to determine how you're going to capture this data and implement the corrective measures. And this is how we are doing at Seva at Home. We are capturing this data of many companies and coming up with the, how many patients have diabetes, hypertension, cardiovascular risk, and take appropriate interventions. Thank you.